Is it fair to say you have a sense of adventure?
I would say so, yes. I do have a sense of it. Less now than I did at your age.
Let's go back to the 1960s for a second. The setting, Dhaka, East Pakistan. You're on an international team trying to treat cholera. How did you end up there, and what role did you have to play?
At that time, there was a war going on, the Korean War. There was a draft, so I was obligated to military service. I was a senior resident at then the Peter Brand Brigham Hospital in Boston. I got a call from NIH, Dr. Robert S. Gordon, Jr., asking me if I'd like to go to Dhaka. That occurred because I'd been writing many letters for alternative service for the draft from medical school onward, and one of my friends that worked at NIH had mentioned that they were finding difficulty getting people to go to Dhaka, that he knew someone who might agree. So I got this call from Dr. Gordon on a Labor Day afternoon. Sounded like a great idea to get my military service, so I became U.S. Public Health Service, working for the National Heart Institute in Dhaka, Bangladesh, at the Pakistan Southeast Asia Treaty Organization Cholera Research Laboratory, fondly known as the Cholera Hospital. At that point, we knew from work by the Navy exactly how to treat cholera patients with intravenous fluids, and so we set up a hospital to demonstrate that that was feasible in a full emergency situation, and devised our own IVs and took care of patients with a very good outcome, about 99+% survival if someone arrived with a heartbeat.
Amazing.
The problem was that in the settings of cholera, IV fluids are not available, nor are people available to use them.
Mm-hmm.
So it's quite apparent in refugee situations there that IVs were not going to solve the problem. And at that point, we knew there was a way to hydrate people, giving the same solutions or similar solutions by mouth as we were giving IV.
What is it like actually treating a patient using this therapy?
Well, it's the most powerful thing I've done in medicine. We often had to do it in public in the street because the patient was in shock.
Well,
And they were called resurrection ceremonies because we'd give 3 liters of fluid, the person would wake up, sit up, and say hello to their family, then we'd move them into the hospital. Why am I in geriatrics? Because when I came back, we were having diarrhea in the long-term care facility.
sure.
No one knew why, and we showed that a large chunk of it was due to C. difficile. Geriatrics is really, I don't look at it as a specialty, I look at it as a discipline that's focusing on the people who have accumulated a lifetime of history. And I'm interested in those people. And right now, in American medicine, when I get a discharge summary, I have no one is saying who the person is you're dealing with. So every note I write, I try to indicate something about the individual, because the heart of medicine is who the person is experiencing the disease.
And so, what is something that only over 6 decades of experience can teach you about clinical excellence?
First thing is that science and humanities blend. You must have them both. Science is powerful when it's applied to things we don't understand. We're not always as successful as we were with cholera, but there are many successes when we diligently apply the scientific method, ask the question, seek an answer with the appropriate technology. The second thing would be that in geriatrics, each individual is a living history, and particularly you can get a direct understanding of what it was like when the steel mills were working in World War II in Baltimore. The broom factory was hiring 12-year-olds at 50 cents an hour for 16-hour days. You can only get that sense directly from a person who was old. And this is one of the joys of geriatric medicine.
Dr. Greenough, thank you so much for your time. That was a CLOSLER look.
Okay, thank you.